when I was trying to think about what to do for today's grand rounds, I thought perhaps I could get you all updated on what's happening new with nerves, in particular peripheral nerves, because there's just a lot of exciting things, and I hope that you guys will find this interesting as well. I need to give a shout out to a couple people, Dr. Biswal and Dr. Odestad, both who are collaborators with us and work with us on, oh, I can take this off. Work with us on Nerve Team. We have a multidisciplinary group to take care of complex nerve patients, and they shared some of their slides. So thanks, guys. So I thought, well, I'm giving a talk to the Department of Surgery grand rounds, and I can imagine that sometimes for you, the topic might be not of interest. That could happen sometime. So I wanted to get a topic that maybe you would find interesting. And why you might find this topic interesting is because every surgeon encounters nerves. Every time you cut the skin, you're going down, you find a nerve. Every discipline has that nerve that you worry about because it causes problems. If you injure a nerve, this could be one of the main causes of persistent pain after surgery. Pain and nerves are intimately wrapped together, and so that would be another interesting point for surgeons. Also, this is a very young field. There's no fellowship in peripheral nerve surgery, really. This is a young field. There is a lot of very exciting and cool things happening because it's a young field. So I thought maybe this would be an interesting topic for you all. And so what I'm going to do is give you this just whirlwind tour of all the things that I think are cool that are happening in peripheral nerves. So this is totally edited by me, and we'll see what you guys think. We're going to start with some of the new diagnostics. We'll go on to some of the new diagnoses that we are treating, and then a little bit about some new treatments that are evolving in this field. So it's a little bit all over, but I think hopefully you will learn something. So for diagnostics, what is the things that we struggle with currently is that current imaging really can't see nerves. They're just not, they're too small. You can't see them. You can't see which one's injured. You can't see if it's getting better. And another problem is you can't localize the painful pathology. So what do I mean by that? You can't localize the painful pathology. So think about shoulder pain, okay? Shoulder pain, pretty common, happens to a lot of people, and you get an MRI. Lots of people have rotator cuff injuries. As you age, you will 100% have a rotator cuff injury on MRI. So you go in, you have an MRI, and you have a rotator cuff injury, and you have shoulder pain, but are those the things? Is it the rotator cuff injury that is causing you pain? The MRI doesn't tell you that. So we don't have a way to image and find out what's actually causing your pain. Or do we? So this is, I think, very, very exciting new work done here at Stanford in the Dr. Biswal's lab. And this is a technique to be able to image what is hurting you. They do a head-to-toe MRI and a PET scan, and they're developing new PET tracers that are going to give you the sort of physiologic signature of what's painful. In particular, the one at the bottom is the sigma-1 receptor, which there's a lot of interest in right now in pain because it is one of the molecules, receptors, really thought to be a nociception in the pain generation. And so I'm going to show you a couple of these images here. Okay, so if you get one of these PET MRIs looking for pain, this is the type of imaging that you would see. So the first thing is you have sort of the rough MRI of this really terribly painful sciatic nerve tumor. Okay, so we can see there's the tumor. At the same time, they're running the PET scan with the ligand. This is the sigma-1. And you can see it has really hot uptake. It's bright red. It looks like it hurts. And then what you get at the end is this last thing, which is overlay of the PET onto the MRI. So you can see that this tumor is painful. And just to sort of compare that, here is another peripheral nerve sheath tumor that didn't hurt. And they ran the same thing, and you can see It's not hot and red and painful looking. It has a blue appearance. So and we've done this for neuromas, where you have a neuroma of a cut nerve. You can see the neuroma. It doesn't hurt, not hot. When it hurts, it's hot. So here we have the ability to image pain. And so they've been doing this all over the body, different things. And I thought, just given the audience, maybe we could talk about some of the things that they're doing in the chronic pelvic pain, using, again, the sigma-1 receptor. So here's some looking at the uterus. And so on the top, you can see the PET imaging of the uterus, and then the overlay of the MRI and the PET. And you can see the uterus doesn't really pick up much of the sigma-1 receptor. Whereas this patient with the severe and painful uterine fibroids, you can see the overlay of the PET and the MRI with the hotness of the ligand in the painful uterus. Here's another patient with endometriosis, looking for endometriosis. Again, sort of lower pelvis with asymptomatic volunteer. You see some general uptake of the PET, but no real hot areas. And then each of the implants sort of lighting up in the PET scan. And when you have the overlay, you can see how they go. And so for just the abdomen, they were able to find for different patients increased sigma-1 receptor for different painful conditions in a variety of organs, including the liver, small bowel, as well as things like the uterus that we just showed. So this has been used in a lot of different conditions. And I was going to show you one of my own patients who we sent for this study. So they sent me this 60-year-old guy. He had this ankle pain, just hurt him every time he's walking. He couldn't even walk a block. His ankle pain was so terrible. The orthopods didn't know what to do about it. They weren't sure, so they sent him to me. They're like, well, maybe it's a nerve thing. Let's send it to Catherine because she could look for the nerve thing. And so I poked and I prodded and I tapped, and I'm like, I don't think this is a nerve thing. I have no idea what the problem is. And so I said, well, maybe we could try this research study, this imaging for you. So this is what his imaging looked like. And if you can look in his calf, on the right side on A, there's like this bright PET uptake. And when you did the overlay of what that bright uptake was, it was actually his plantaris muscle, which had some scarring in it from the prior trauma. And so if you think about it, the plantaris muscle is this little tiny weeny muscle with this long tendon. And so what we thought was happening was he had this scarring in his plantaris muscle. So every time he's walking and his ankle is pulling on that plantaris muscle, he's irritating that muscle, he's experiencing pain, and that's why it was so hot, and that he was feeling it in his ankle. So we did a tenotomy under a local MAC. You can't really see, but the incision is just on that posterior bit of his ankle to sort of uncouple the muscle from the ankle movement. And this is something you can do because some people are even born without a plantaris, so this is a totally expendable muscle. And he was fixed. No more pain. We would never have gotten to that diagnosis without this imaging. So this is done here at Stanford, and I think is really, really a cool new thing. So this imaging has enormous potential for us to be able to visualize and treat our patients, to be able to figure out what is the pain generator, and is a really exciting new diagnostic. All right. Any questions on that before I go on? Okay. All right. So that's what's new in diagnostics. So now we're going to go in what's new in diagnoses. And we're going to talk about a few different things, including new nerve compressions, a new viral thing called acute flaccid myelitis, COVID-19 in nerve, and amyloidosis. So, like I said, a whirlwind. So nerve compressions. Nerves can be swollen and then compressed because they are transitioning through a tight tunnel or going around a curve, and this can result in pain or loss of function. The nerve compression that you all know is carpal tunnel syndrome. But what we're learning is that there are other nerve compressions that cause serious problems. And I'm going to talk about two of them, migraines and trip and falls. Okay, so head pain, migraine, monster problem, terrible thing. It is the third most common disease and the sixth most disabling disease. In the United States, 1 out of 7 patients have a severe headache in the last 3 months. And this disproportionately impacts people of working age. So this is a huge problem with huge costs. And actually, surgery has a role in the treatment of migraine patients. And so how surgery, we recognize that surgery had a role in migraines is actually kind of interesting. There was a cosmetic surgeon, and he's doing facial rejuvenation, facelifts, Botox, doing all these things, and his patients are coming back and saying, "Doctor, you know, I look fabulous, and I don't have migraines anymore." And so he just kept hearing this. The patients are coming back saying, "Well, my migraines are gone." And so he started to think about this, and he realized that some of the exposures and the Botox were decompressing or relaxing tight structures around nerves in the head and neck. And so he spent his career figuring this out and showing that these nerves cause some of the head pain associated with migraines. The nerve that I most commonly treat in my own practice is the occipital nerve. So the occipital nerve is in the back of the head, and it comes from deep to superficial, and it can cause this terrible posterior head pain that sort of wraps around, can even go to your eye. Can be sort of brought on by a whiplash injury or a trip and fall where you're hitting your head, or no trauma at all. And so people have looked at this occipital nerve in particular and then found these pinching points as it transitions from deep to superficial and turns corners, and has marked it out so that you can do a decompression just like you would do a carpal tunnel on the occipital nerves. So this would be sort of the exposure. It's an outpatient procedure. You make a little incision on the back of the head, and then you find the nerves. You just release them from their tight fascial compression points, close, and they go home with minimal restrictions. And I don't know if you can quite get a sense. These nerves are really far larger than I would ever think for something in the back of the head. I mean, you know, it's bigger than the one to your index finger. So they're pretty sizable. So do these surgeries work? What's the evidence? So in my experience, this is one of my best surgeries. If these people have this unrelenting head pain, people had head pain for 10 years, and when you decompress the nerve, it's much, much better. Most people are better, not perfect. They say, "Oh yeah, it's way better, but I still have, you know, a headache, you know, once a month or something like that." So I have, though, had people where you just decompress it and it's done. Headaches are gone forever, not come back. I haven't had them recur. And some people, it doesn't work at all, about 20%, so I let people know maybe it's the wrong diagnosis or something like that. And I would say that the evidence is pretty good for these operations. There was a randomized controlled trial with sham surgery. I mean, there's not much better evidence than that. And basically what they did is, for some of the nerves, they found them and did the decompression, and then some of the nerves, they went down, they saw the nerve, and they stopped. So that was the two different things. And what they found was that for the ones where they found they did the whole thing and they decompressed it, about 57% had complete elimination of their headaches at 1 year versus 4% in the sham group. Interestingly, if you look at this improvement, the surgery group had 84% improvement, but they also had 60% in the sham group had improvement. I think there's probably a couple things with that. One, you cannot underestimate the placebo effect, especially for pain-relieving operations. They say 20 to 30%. But also they did go down and identify the nerves, so potentially they were doing some decompression just in their exposure of the nerve themselves. And then a recent review of sort of what's the evidence out there right now shows that for greater than 50% reduction in pain for an occipital migraine, the rates range from 80 to 94%, which is my own experience. It's a great operation. Here was the long-term follow-up, so maybe, always with pain procedures, you're worried it's going to come back. And if you look at that top line, sort of a busy table, but frequency of migraine headaches per month was 11 at baseline, then it went down to 4 after surgery, and at 5 years it stayed at 4, some rebound or recovery. So there's a lot of new interest in, are there other nerves out there that we are sort of should be more aggressive about decompressing? Dorsal scapula, lateral femoral cutaneous nerve, anterior cutaneous entrapment syndrome. There's just a lot of interest in the fact that perhaps there are other nerves in the body that are entrapped causing pain that we can treat. So when I started my surgical residency, I had this old teaching that if you operate on pain, you get pain. I think we probably all have heard this one, right? So sometimes, occasionally, perhaps, if you operate on pain, you can get happiness. So the next nerve compression I'm going to talk about is not actually a painful nerve compression. It's one and trip and falls. So it's the peroneal nerve and trip and falls. So another enormous problem that potentially nerve surgeons can have some impact on. So just to give you some scope, $50 billion a year are spent on non-fatal falls. It's enormous, and 800,000 people are hospitalized. We all see the sort of consequences of trip and falls. And so there is some emerging evidence that the common peroneal nerve entrapment could be an unrecognized cause of these trip and falls. And so this started with the WashU group, and they went into the hospital and they just looked at all 100 inpatients. So these are just people in there for pneumonia, UTI, all comers. And they did a physical exam on them to see if they had signs of entrapment of the peroneal nerve. And the ones that they did the physical exam on were the ones who had already been assessed as a high fall risk assessment. Patients come into the hospital, they get that fall risk assessment. So they picked the people who had a high score. And in that group, 31 out of 100 had signs of entrapment of their peroneal nerve. They said, wow, that's pretty amazing. Let's take this next level. So the same group went into just the clinic. This is all comers, and again, did the physical exam, looking for signs that the peroneal nerve might be entrapped at the fibular head. And they found that about 3% of all comers had signs of this. And you might say that's just crazy talk, 3%. But it's not crazy talk. Carpal tunnel, the one that we all know, actually has a very similar incidence. And the peroneal nerve here is actually at quite a bit of risk. If you look here, it's just behind the knee and it's wrapping forward, wrapping anteriorly. It's quite near the surface. It has bone beneath it as it goes under the anterior compartment, and so it's just a setup for compression. What you get symptomatically is a little bit of you get a little numbness on the top of your foot, which you're never going to notice. Carpal tunnel, you notice because you get numbness in your fingers. And what does the peroneal nerve do? It helps you lift up your ankle and lift up your toe. So if you have just the tiniest bit of weakness, that toe is just not quite going to clear, and that every little wrinkle in the sidewalk becomes a little bit more of a risk for you, and you can catch that toe, trip, fall. So imagine early recognition and treatment could reduce falls. If you could find these patients who have this early symptoms of peroneal things, you can treat them. What would that treatment look like? There could be physical therapy, but also it could be just as simple as behavior modification. every time you're crossing your legs, you are putting compression on your peroneal nerve. And so if you sort of change your behavior, change your sitting, you may be able to decrease the swelling. This is what we do for upper limb entrapments. Entrapments of the ulnar nerve, we say, don't sit like this. Entrapments of the peroneal nerve, don't cross your legs over your knees like that. And there also is a surgery quite similar to carpal tunnel to release the pressure on the carpal tunnel, on the peroneal nerve. I do this as local MAC, and just it's a small incision, find the peroneal nerve and release it from its compression. Some people even do it under straight local. I haven't quite gotten there. And this, just like carpal tunnel, can release it. So I'm going to put out there that nerve compression is not just your parents' carpal tunnel anymore, that there's a lot more going on here that we as surgeons can help improve upon. All right, so that's all I have to say about nerve compressions, migraines, falls. We good? Okay. Like I said, Whirlwind Tour. So I'm now going to talk on one that's actually a lot scarier. This is a newer viral disease called acute flaccid myelitis. It is quite similar in sort of phenotype to polio. It is caused, we think, by an enterovirus, and it only gives symptoms in children, not infants, but young children. It impacts the gray matter of the spinal cord, perhaps the microglia, and it results in paralysis in otherwise healthy children. It has been sort of recognized since 2012. We certainly have been seeing these patients in our pediatric peripheral nerve clinic since then, probably maybe even earlier, not knowing what we were seeing. It has a biennial occurrence. It comes on a year, off a year, on a year, and each year until recently, it had been getting more and more prevalent. 2020 was the year that it was supposed to come back again, and then COVID came and shut everything down. So it's really unclear what's going to happen once children are playing again together for this. And so this is sort of one case of what you see. It is different than some of the other peripheral nerve injuries that we see because it's not in a certain cervical level. The entire shoulder will be taken out. So all of the shoulder girdle, including the trapezius muscle, which is from a cranial nerve. And so this is a very common presentation. So the child's unable to move their shoulder or move their arm. So the initial treatment is supportive. Sometimes these children need to be ventilated and monitored. There can be sometimes recovery, but it's only about half the time. And persistent weakness is common when children have this acute flaccid myelitis. But surgeons actually can help with the treatment of acute flaccid myelitis sometimes, depending on the deficits. We can rewire the nerves, restoring function that has been lost. So for the child that I showed earlier, he had loss of his shoulder girdle muscles. We actually took the nerves from the intercostals and we rerouted them and hooked them into the suprascapular nerve to be able to give some shoulder abduction and some external rotation. And because they are children, they heal. Recovery is beautiful. And so the results, when you get to this early enough, actually have been really good. So a scary thing that actually surgeons are an important part of the treatment for. Another virus that is scary is COVID-19. And COVID-19 has actually quite a bit of neuropathy associated with it. You've all heard probably about Guillain-Barré, Bell's palsy, these things that are out there. There's also some general neuropathy that's been associated with it. They don't think it's actually the virus attacking the nerves. I think it's more an autoimmune type of condition, or perhaps even a medication toxicity. And then there's also the positioning, especially of our most sick patients in the ICU, that they may end up with nerve palsy afterwards. It may not be the virus at all. And so because the patients need to be proned, this is a particularly difficult positioning, especially for the upper limbs and the nerves in the upper limbs. They looked at 115 patients that needed to be proned with COVID-19, and I think like 15 of them had a significant neuropathy in their upper limbs afterwards. The most common nerves that were impacted were the ulnar nerve was number 1, and number 2 was the brachial plexus. So this was just some recommendations that one of my nerve buddies came with, Tom Quick, as how to help position the arm if you're proning to really offload the stresses on the nerves in the upper limb with the swimmer's posture, where you have sort of one arm up and one arm down, but not taking it sort of past 90 and sort of lifting up the scapula, so you're sort of not stressing the brachial plexus. So I thought that this was actually an interesting and useful thing for proning these. And like I said, there also seems to be just a general neuropathy that happens. These are not patients that were necessarily prone, but it's about 9-10% of patients seem to have some neuropathy after their COVID-19, including the peroneal nerve and the sural nerves. It seemed to be particularly problematic in patients who already had risk factors like diabetes, and there's just some thought that the severity of the disease took patients who were sort of on the edge and sort of tipped them over to having symptoms afterwards. So COVID-19 may also be bringing some patients to the surgeon. And just because we have to go all over the map today, we're going to talk about amyloid cardiomyopathy. And I'm sure you're sitting here going, "What? That's the heart. That's not the nerves. What are we talking about here?" So amyloidosis is an under-recognized cause of heart failure. And I think in the past, we didn't look for it too hard because we didn't have any treatment for it. So we knew it was there, but we didn't have a treatment. But now there are new medications that actually can help treat and prevent the cardiac effects of amyloidosis. And there's actually some very exciting genetic interventions that are going through and actually quite close to human trials to change, to prevent the amyloidosis. So now it becomes increasingly important for us to find out, well, who has this? Okay, here's where the nerve surgeon comes in. So it turns out that the first symptom for the majority of patients with one of the more common variants of amyloidosis is carpal tunnel syndrome. 55% of patients who had this variant of amyloidosis actually had carpal tunnel syndrome far before they had any heart effects. And so a group in Cleveland Clinic said, well, I wonder if you could, do something at the time of carpal tunnel release to try and identify these patients. And so they screened patients. So it was men over 50, women over 60 who had carpal tunnel syndrome. And they did the carpal tunnel release, and they just took a little tiny bit of the soft tissue around the nerve, and they just did a Congo red stain. So cheap, there's nothing fancy here. And they found that in their population, 10% of the people coming in for carpal tunnel who met those demographics actually had amyloidosis. And so here you have sort of an easy, cheap test to identify people with amyloidosis potentially before they have the cardiac effects. And now we have a treatment that we can offer them. So we started doing this in our own patients here at the VA, and we found that actually 30% of our Congo red stains are coming back positive, and our carpal tunnels. And so what I'm hoping is that we can promote this as a sort of change in practice for people doing carpal tunnels, that if you have a patient who is in this risk factor, that you would go ahead and send a small piece to look for this and screen for amyloidosis. All right, so those are all the new diagnoses that you have to start, well, not all of them, many of them that you have to start going for through if you are a nerve surgeon. And so just to sort of take us full circle, we went from diagnostics to diagnoses, we should talk a little bit about treatments. And there were so many to choose from, I didn't want to overwhelm you. So I'm just going to talk about the use of peripheral nerve stimulators and electricity. So electrical stimulation has been used for pain for a really long time. Spinal cord stimulators have been around for a long time. I think my high school physics teacher had one. And the way that this is thought to work is something called the gate theory, that if you have non-painful stimuli, your brain just can't process the painful ones as well. So the patients feel like a tingling or a buzzing, but it's not painful. And so their perception of their pain goes way down. Spinal cord stimulation is great, but it's not targeted, right? So if you have a median nerve pain that we can't fix surgically, you could get a cervical stim, but that's a little bit broader than you would want. But it was really hard in the past to do a peripheral nerve stim, say for the median nerve, because you had these monster batteries, like where would I put that in the arm? Or you'd have to have these long leads that crossed a bunch of joints and they would fracture or move. And so the idea of a targeted nerve stimulator to a particular nerve wasn't feasible. But technology has really advanced in this world, in this area. And so now there's several different percutaneous nerve stimulators that can be directed to one peripheral nerve. And the reason that we can do that is because they've been able to make these things far smaller. So that's the lead in the hand. It's flexible and soft, and so they can be implanted using an ultrasound. This is the stim router, I think it's called. And so under ultrasound, using a 2E needle, they place it next to the nerve. They then close the skin. So there's nothing hanging out of the skin. And then that Band-Aid that's on the shoulder, that's the power source. So it's an external pulse generator. So when the patient wants it, they put the Band-Aid on their, over the lead. They can turn it on, they can turn it off. And so this has really opened up a lot of nerves and just targeted nerve pain therapy that we didn't have before. One of my patients who we gave this to 5 years ago, she doesn't use it anymore. She said that when she got it, she used it a lot and then she used it less, but just having the ability to turn it on if it flared was such a relief to her that she worried about the pain less, which I think also helped decrease the painful signal. And so having that control and giving it to the patient for their pain, I think it can't be underestimated. Here at Stanford, pretty early adopters of putting these peripheral nerve stimulators in. This is from Dr. Odestad and Dr. Pritzlav have shown me, shared this slide with me, but they've used this for a lot of different nerves that didn't have a good, easy surgical fix. I think it's been wonderful for like the saphenous nerve that gets injured, say, after a knee replacement, as well as after our hernia repairs. Sometimes it's hard to figure out where the nerve injury is or something like this. It's a very low risk thing to try see if you can reduce the pain. So this is one of my own patients who had a median nerve injury, had terrible pain, couldn't even close their hand. It had this sweaty, swollen CRPS type looking hand. Put in the peripheral nerve stimulator, and he was able to start working with therapy. He actually bought an extra battery because he liked to have it on all the time, never worried about charging it. And so here's just some of the patients in the Stanford experience, and you can see not everybody got improvement, but a lot of people had a reduction in their pain when they were able to use their implant. So this is a really nice tool to add to our treatments of pain and peripheral nerve injury to be able to target that nerve that is actually causing the pain. All right, this is my last one because I just think this one is also really cool. Sleep apnea. Another huge monster problem. Do you see all the huge monster problems that come to the peripheral nerve? We've got falls, we've got migraines, we've got sleep apnea, we've got pain. Anyway, so sleep apnea, another monster problem that is out there. And the CPAP machine, a lot of people can't tolerate it. It kind of stinks in a lot of ways. It's very effective, but it's problematic. There is one FDA-approved device to use peripheral nerve stimulation to treat sleep apnea. And this is a little cartoon where you can see they actually have like the pacemaker battery. So I'm waiting for generation 2 where you could get the little Band-Aid battery, but they have a pacemaker put on the chest. You have a lead that goes on towards the respiratory muscles, and then you have another lead that goes up to the hypoglossal nerve. It senses when you are going to be obstructing, and it gives you a small electrical stimulation so that you stick out your tongue a little bit so that the tongue doesn't fall back and you don't obstruct. I've talked to patients who've had it, and they say you can sleep even though you're getting your tongue is sticking out. And they said you can turn it up and actually feel your tongue sticking out, but you turn it to a low level that you can tolerate and that you can sleep. And they have looked at it, and it really reduces those apnea, hypopnea events. It has very low morbidity, and when they've done a cost-effective analysis, it's quite cost-effective. And so this is just one other sort of novel way to be able to use nerve stimulation to try and reduce morbidity. There are many, many other things that I could talk about, but I thought this was maybe a little bit overwhelming, and I wanted to leave some time for any questions, or if you had questions on patients. Here at Stanford, they are doing nerve transfers for corneal numbness and blindness. There is nerve stimulators for overactive bladder. There are nerve stimulators. I mean, there's just a host of things in this young field that are available to you. Thank you very much for giving me the time to take this Whirlwind Tour.